Welcome to JAMA AI Conversations. I'm Roy Perlis, Editor-in-Chief of JAMA AI. My co-host today is Dr. Linda Brubaker, Deputy Editor for JAMA and Editor-in-Chief of JAMA Women's Health. Linda, before we introduce our guest, could you say a few words about your vision for the new JAMA channel?
Thanks, Roy. I'm excited to introduce JAMA Women's Health, our new initiative which launches September 5th. This initiative is dedicated to advancing clinical care across the spectrum of women's health. As you know, Roy, women's health goes well beyond the commonly recognized issues such as reproductive health, menopause, and breast cancer. In fact, women's health spans nearly every aspect of health and healthcare, including primary care, cardiology, imaging, and many other specialty areas. The growing number of rigorous studies that are being published in JAMA and the JAMA Network provide a curated source of trusted clinical information. This growing collection of content within JAMA and the JAMA Network is now available at JAMA Women's Health.
So, to help launch this new initiative, we wanted today's show to highlight the intersection of AI and women's health, and there's a lot to talk about there. And we have the perfect guest to do that. Our guest today is Dr. Linda Moy, a leading radiologist and researcher whose work focuses on breast imaging, AI applications in mammography, and advancing early detection strategies. She is the inaugural Vice Chair of AI in NYU Langone's Department of Radiology. Dr. Moy, welcome.
Thank you very much for having me.
Dr. Moy, I wonder if we could just start out by having you describe why your work is particularly important in women's health right now.
Sure. I've always had a deep interest in women's health. I just realized we're not doing enough to really get women to come in, to do the screening studies, to recruit them in trials, to really help them understand the benefits of all we can offer. And when I dug deeper, I just realized that, as physicians, we don't do a good job of engaging patients. We know that women are the portal to the family. They drag in their husbands, their kids to have studies, but they don't find time for themselves. And then I recently came across a study saying, well, we've known for a long time that women have a longer lifespan than men, but it turns out that much of that time is spent when they're in poor health, with disability, with lots of things that we're not doing a good job to reaching them. So that has really renewed my interest in trying to see what we can do going forward.
I really like that you highlighted the longer lifespan, but a shorter health span, which is a common theme that we see in women's health research. You've outlined some of the unmet needs and the gaps. And how will your work start to fill these gaps?
I am an imager, so one of the good things with some of these AI tools is that it serves as a second reader, a pair of eyes to look at whether it's a mammogram, ultrasound, or MRI after I've read the case. So that will hopefully make me a better radiologist. Maybe I can find a few more cancers, but more importantly, I think there's usually what I call a higher rate of false alarms or false positives, and that generates a lot of stress. So if we can use an AI tool to go ahead and bring that down, that's important. But where I think right now we're noticing a lot of potential for AI is to translate the science, translate the report. So we spend a lot of time now generating patient-friendly reports. We try to close a loop if they need follow-up exam and all that. And we also now have developed lots of educational material that I think is understandable to women with different literacy in different languages. So I'm really excited that the outreach that we've been passionate about, that we can finally have effective tools to reach these women.
That's really helpful, since we really know that if people don't come for their breast cancer screening, our chance of picking up the cancer early and getting them effective treatment is greatly reduced. So it's great to hear about that work. I know there's some other technology advances too, and I'm going to hand this over to Roy to talk a little bit about some of the technologies that you're using for the cancer detection itself.
Yeah, so I was reading a paper you published not very long ago in another journal, but we'll forgive you for that because I think it was your journal, describing a bunch of different algorithms and how they performed in cancer detection and mammography, right? Sort of a bake-off of tens of algorithms. What's your sense of the state of the art? I mean, how good are they as a second set of eyes?
Okay. So I have to say that they are pretty good, but I believe not as good as a radiologist. What we've always kind of grappled with is how do we scale up a test that we think is important, whether it's this or now we're doing liquid biopsy? And the answer is that these tests, it actually turns out that their predictions are not always accurate, or they may be a disagreement between what we see and what they see. And I think this is where the clinical implementation comes in by saying it's different how you incorporate the AI results when you have a patient in front of you. We talk to every patient versus when you're reading, by yourself in a vacuum. I call it like a human AI symbiosis. There are some cases where certainly, like, wow, that AI made a really good call. I may not have appreciated that. And there are cases where, again, this issue of the false positives. I think that the developers for AI are just like radiologists. We don't want to miss the cancer, but as a result, the threshold is set so that we still do have lots of these false alarms. So I think we're getting there, Roy, but more work does need to be done.
I was surprised that for any given algorithm, the sensitivities were in the 30-ish% range. And even when you ensembled them, you got to 60-ish. I naively might have expected better performance. It's never fair to say we have to get above this threshold, but if I were to put you on the spot, how close are these models to the point where you would say, yeah, as long as they're being used in concert with a human, they're ready? Are we there?
Sure.
Are we in striking distance? How far away are we?
Yeah, I would say we're definitely in striking distance. And I think part of it too is the radiologist has to learn how to use the AI. So where does that low 30-something% come from? Well, it comes from two things. One is that for a mammogram, we look at what's called the breast density. It's that normal background pattern. For women that have dense breasts, small cancers are little white spots or little white dust particles, calcification. So it's much harder to identify that. And then the other thing is that the technology for medical imaging AI was really based upon originally work that was done on natural images. Here's a person, they're right in the center image, it's the majority of the image, and so it's easy to train. Whereas for mammograms, some cancers that we're finding is only about 5 millimeters, 6 millimeters, so it truly is a needle in the haystack. So much of the scaling up is really getting the AI trained to pick up that small area of signal and then being able to process those results quickly. So these are really moving at a very fast pace. So I do think that we are quite near there in the next few years.
I want to call a little bit of an audible here. A previous guest talked about when we need patient consent for AI. And it was a really interesting discussion. And what you were describing just made me wonder, when we routinely have the radiologist sitting next to, figuratively at least, the computer, do the reports need to say this was read in part by an AI or we used an AI? In other words, is this going to be something that patients consent to, or is this just going to be so much a part of what you do day to day that it probably doesn't need to be explicitly disclosed?
That's a great question. And at least for breast imaging, we went ahead and use our prior reports. So breast imaging used to use something called computer-aided detection, or CAD. And back then, we always included that in the reports. This new AI is a little bit nuanced. So we put into reports, and I tell patients, I'd like to use AI to assist me, and usually they're interested. And I have to say, most patients are glad that we do that. I've had a few patients who mistrust the AI and said, you know what? No, thank you. I'd rather have you look at it or you and another colleague look at it. But I'm a big fan of transparency, so I always tell patients that we're using it.
I'm so glad we're talking about this because in so many areas of women's healthcare, tools, techniques, procedures have not always been rigorously evaluated before they brought in to bear on women's care. And some things have been brought too soon, and women have suffered because of that. And in other areas, women have just been left behind, and it was assumed that their physiology and everything went along a male algorithm. So we don't want too fast. We don't want too slow. We want just right. What barriers, though, do you see, since not everybody may be following the same path that you're following here?
Yes. So unfortunately, there are barriers to making sure, let's say, that AI works well across all women. So as you mentioned, the AI is really learns from prior data, and most of the clinical trials, have predominantly men. There's lack of sex disaggregated data. And so all that, really needs to change. And we're becoming aware of that. And I'd say something else I'd like to introduce a concept is called digital twins. So this is the idea that, okay, we would like to really predict how well, let's say, an MRI will work on me, given my family history, age, and risk factors. And it's hard to know whether they can find that particular pathway that would be ideal. And so now the digital twin creates a synthetic version of me. It combs through lots of data in the electronic health records, looks at a prior history, and then it correlates someone who they think matches all of my risk factors and my past medical history. And so that, believe it or not, in the last couple of years has really sped up the recruitment of women and various minorities for clinical trials. So this is where I think we can really leverage AI to make a difference. And as you mentioned, Linda, to safely test patients, whether it's going to be medications or a new treatment, pretty well, and not to rely on the fact that it's past FDA approval. Then afterwards, we're going to go ahead and just do some post monitoring, and seeing what happens. So I like this approach of really trying to figure out the various scenarios before we implement it widely.
I'd like to ask one follow-up question on that. How will you know if this is helpful? What will your metrics be?
So the metrics would probably be to have a similar diagnostic performance across various segments of the women population. Certainly, other metrics that we really talk about is patient safety. Are there complications that we didn't expect, or is it higher than what has been historical norm? Certainly, we do a lot of patient engagement with surveys to see how well that they like a particular medication or tweaking a medical imaging exam. That's quite important. And I would say for us, image quality, we do have both some quantitative and subjective views. So we have lots of metrics that we can do to make sure that we're on the right track.
I want to kind of broaden things a little bit and talk a bit about mammography and its strengths and some of the limitations. Where else in women's health imaging do you think AI is most promising? So again, we sort of tend to focus in on mammography because I think it's the one that, obviously it has such public health impact. People understand what it is. They have an experience with it. But where else do you think AI is really going to change things over the next few years in women's health imaging?
Sure. So my hope is really that AI can lead us to what we all say is precision medicine. We've been talking about that for 20 years, and it's still not a reality. And so I really do think that the money is in precision medicine for screening indications. And so there's a couple of advances. And what I like about AI when you're looking at this, it's important. It's the longitudinal data, so we can pick up the very subtle changes. And so that, as a doctor, I haven't been able to do. So that's one thing that I'm really excited about. And I think there's something that is shaping us. The other way where I think AI can really be a game changer is this concept called opportunistic screening. So I may come to the emergency room because I got into a minor car accident. And to make sure that I'm okay, the physician's going to order a CAT scan of my chest because I'm complaining of some chest pain afterwards. And in the past, we just focus on a couple of things. Any broken ribs, anything to suggest there's a laceration or cut to the lung, and then we're done. But now it turns out that there are information. So we say images or data. There's all these other areas that we can go ahead and look at. So let me give you a specific example. You get the CAT scan of the chest. We're looking at your thoracic spine in the back. And that information now, we can go ahead and measure the bone density. And we can say, wow, Linda, you don't have any fracture of your ribs or your spine, but wow, your bone density is a little low. You should start taking some of these calcium supplements. So all of a sudden, I can get that. When you get the CAT scan of the chest, it images your heart. So it looks for calcifications, which is sort of a surrogate for arteriosclerosis in the heart. So you get these calcium scores. And then there's another area that we call it sarcopenia. So it looks into the various healthy muscles in your chest or your back. It measures not only how big these muscles are, but how much fat there is in there. So the more fat, there's a little bit more atrophy. So these signs of sarcopenia actually predicts how well patients will do recovering, let's say, after surgery. So all of these helps us be able to identify what additional resources we may provide for patients and whether they need to be followed a little bit more carefully.
That's really an exciting way to think about something that's happening routinely anyway in that clinical setting. I want to talk a little bit more, too, about following up on the areas that you talked about before, access to screening and expertise, and well beyond mammography. Hospitals in rural centers or less advantaged places compared to New York may have financial challenges implementing AI-assisted imaging or interpretation or patient communications. Do you have any thoughts on kind of equitable or reasonable ways to make sure that patients across our globe have access to this, or at least in our country?
Yeah, these disparities of healthcare, which will get worse as we have the aging population, right? Again, they have more comorbidities as well as the supply trend of fewer physicians, nurses, and so forth. So what can we do to level the playing field and what can AI do? So I have to tell you, I really have been impressed that patients are very accepting of telemedicine, that we can reach out to them. So now through our PACS system, we are covering sites throughout the New York State area that are in rural areas that we can get these images sent to us. We can then set up appointments for us to talk to them or for patients to speak to, let's say, their GYN surgeon or their breast surgeon or radiation. I think the fear of unknown sometimes is these things, that also drives issues with access. Certainly, we're well aware of the social determinants of health and how that affects people. And I said, I don't care how good of an x-ray I have. I can have the best mammogram in the world. But if I can't get it to the right patients to use, then I really haven't done any good. So something that we've done a lot of is actually looking at AI for ultrasound, even in the breast. These are mostly in, I would say, the LMICs. And so here, first you might say, hey, Linda, you just said mammography is like the most widely used screening test. But now you're saying that for LMICs, you're going to go ahead and use an ultrasound. And I have to say, you have to work with the tools that you have. In some of these countries, we don't have good mammogram machines that we can use. We don't have technologists who know how to position the patients. And if we had those, yes, we could send these images to folks here in the US or the UK. There's a lot of this to read. But it turns out that ultrasound is actually a technology where now we have good data showing that AI can train people that have no or limited medical experience to learn how to do that. And then this point of care ultrasound. So using my cell phone, this is going to be the monitor. And there is a transducer of this size. Let's say you can imagine a highlighter that's attached to that. And then with AI, it can train someone to make sure they're taking the correct images, holding it at the right position, taking images, throwing AI on top of that so that it can at least be a first quick read of saying, okay, You will either come into the clinic and do more work, or, okay, this is likely low. So I'm hoping that that's going to address the disparities. But I think the point I'm trying to make is that we're now realizing we don't need to accept the workflow as is. We can be creative and actually maybe a little bit disruptive and say, what's the best way to do this with limited resources to really get the best possible outcomes? And that's what I'm really excited about.
So you sound very enthusiastic that low and middle income countries will be able to benefit in the near future.
I think that's a perfect place for us to wrap up because your enthusiasm for these tools is palpable. And I love what you said about not needing to accept workflows the way they are, right? That this is an opportunity for us to sort of reimagine how we provide care for people. And more generally, I really appreciate your willingness to share your perspective and your enthusiasm with us today.
Great. Thank you.
Yeah, and thank you so much, Dr. Moy, for joining us today. I really look forward to seeing how these advances really move women's healthcare forward. Thank you for joining us today.
I also want to thank my guest host today, Dr. Linda Brubaker, and congratulate her on the launch of JAMA Plus Women's Health. To our listeners, thanks for joining us. You can find links to some of Dr. Moy's work and to JAMA Plus Women's Health in the episode notes. To follow this and other JAMA Network podcasts, visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. We'll see you next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.